I'm Katie. I come from Prima Pharmacy. We are a digital fertility pharmacy. We work with thousands of patients who are going through IVF and egg freezing, and they come to us with many questions about their specific treatment, about how they can maximize their chances of success, and a lot of specific questions about how nutrition can impact your chances of trying to conceive. So we're speaking here with an expert today, Dr. Gleicher of the Center for Human Reproduction, and it'd be great if you could introduce yourself to our audience.
I'm Norbert Gleicher. I'm the medical director and chief scientist here at the Center for Human Reproduction in New York City. I have been doing IVF for a very, very long time. I am one of the last first generation IVF people, I can say. In those days, I was a department chair still in Chicago when I started the first IVF clinic in Chicago, and actually in the whole Midwest, and one of the first in the country. And so I have been at this for a very long time.
So we're really lucky to get to speak with you today and share your expertise with our audience from all across the US. So there's a lot of information online about how diet and nutrition can impact someone's ability to conceive. So what do you recommend patients prioritize in their diets when they are anticipating to go through IVF?
Yeah, that's a very good question, and an important question that you see more about written and published almost every day. But you have to be careful with the information, like always. There is a lot of good information, but there's unfortunately also a lot of not so good information. So let me lay out a few general principles when it comes to nutrition and infertility. In general, fertility is the highest goal of nature, because it maintains the species, and that is the ultimate evolutionary goal. And therefore, nutrition is obviously important, because you don't have to be a medical expert to understand the very close connection between what we eat and how we feel and how healthy we are and how old we get. All of that is becoming increasingly clear and has led to the slogan, food is medicine, and in a way that is absolutely correct. And it also applies, obviously, to fertility. But at the same time, I have a very hard time with promoting one specific diet. There are advantages to various diets, and there may be some diets that are better than others for specific groups of women. And therefore, to say Mediterranean diet for everybody, yeah, Mediterranean diet is certainly a healthy, maybe the healthiest diet, and certainly will not harm many other people. But there may be some people who would benefit from a different diet, or would benefit more from a different diet. So, like in medicine in general, treatments have to be geared at the patient population they are supposed to serve. Just because something works in one patient population does not mean automatically it works in another patient population. So that's a very important first point. The second important point is that we all know what is healthy diet and what is not healthy diet. If that now involves a little more meat or a little less red meat, we know what's healthy and what is not so healthy. A hamburger is obviously not as healthy as a grilled fish, and a bacon meal is not as healthy as a green salad. We don't need to be medical experts to know those things. So in principle, if you want to get pregnant, eat healthy, live healthy, exercise, maintain your weight, which is another very important point regarding what you eat, because obviously, depending on whether you're slim or very obese, what you eat matters in different ways, and once again, matters in terms of what you eat, etc. So I cannot give you a general rule about what to eat, maybe except in one situation where there is really significant data that is relatively easy to pinpoint, and that is when it comes to the point of inflammation. Now, inflammation is one form of what we also call hyperactivity of the immune system. And the immune system is very, very important in pregnancy, much more important than even appreciated by many of our colleagues who still widely believe that pregnancy is basically an endocrine condition, a hormonal condition. And while hormones are obviously very important in infertility and are obviously very important in pregnancy, I would not call pregnancy an endocrine condition, but I would call it an immune condition, because the first thing that needs to function well in order for a woman to conceive is not her endocrine system. It's her immune system, because her immune system is geared at protecting her from any form of invasion into her body, and that includes an embryo. And by all basic rules of biology, a functioning female immune system should reject every embryo that is trying to implant. Yet that does not happen. And it doesn't happen because, as we now are starting to understand, there is a conversation going on between the implanting embryo and the maternal immune system, in which the implanting embryo says, "Hey, I'm here, let me in." And the maternal immune system then kind of feels that embryo out. And if they feel it's a good embryo, then indeed reprograms itself so that it wouldn't reject this invader, which it is supposed to immunologically reject, because it genetically is half the partner's genes. And if that same woman were to get a, let's say, kidney transplant from her partner, she would violently reject it. Yet the child that she gets from her partner, she's not rejecting as long as she has a normally functioning immune system, because the immune system reprograms itself to tolerance, to tolerate that invader. Now, immune systems that are hyperactive, and that can be due to autoimmunity, can be due to inflammation, or it can be just due to being hyperallergic. Hyperactive immune systems don't reprogram themselves very well. And therefore, women who have hyperactive immune systems, therefore, have a harder time getting pregnant and have a higher chance of having miscarriages once they do get pregnant. And one of those things that can make an immune system hyperactive is if there's an inflammation somewhere in the body. And therefore, the only real hard data that I am familiar with that would suggest that a specifically outlined diet will help is in women who have evidence for inflammation in their body. And in those women, an anti-inflammatory diet will have significant benefit. And that means no wheat, usually no dairy, and as little sugar as possible. Now, many colleagues say that is good. That is a generally good diet. Why doesn't everybody go on that? And frankly, I have no problem with that, except that it's obviously restrictive. A lot of people love gluten. And if they're told they can't eat all the breads they love, they're not very happy. And so I usually tell patients who ask me about their diet, stay away from whatever gives you indigestion. If there is a food that makes you gassy or crampy or gives you brain fog, we all know those foods. And those are the foods that are usually inflammatory for that. So if they stay away from those, they will probably reduce their inflammation. And if they want to quantitate it, there are inflammatory markers that they can have checked, like the SED rate, like the C-reactive protein, like the IL-6 and some others, and can see whether they have inflammation in their body. And if they do, then an anti-inflammatory, gluten-free, dairy-free, and sugar almost free diet clearly will help. But all other diets, whichever ones you want to use, have advantages and disadvantages, and I would not just prescribe them to everybody.
That's super helpful advice. And so you've shared some insights on what patients can take away from their diets to help with inflammation. Is there anything, whether it's a type of food or a type of supplement, that could help improve your immune system?
Well, that is again a very good question. And in principle, the answer is yes, but again with great limits. And the limits here are that we know certain effects. We know that certain spices can do certain things. Again, some are considered anti-inflammatory. Our Chinese colleagues who want that women go into labor, feed them certain mushrooms in their meals. And in my experience, that works sometimes. So there's no question that, once again, food is medicine and food can also be preactive. But I would have to say that beyond what I already said before, that healthy is good and unhealthy is bad, there's relatively little specific data to say eat that and that and that, and that will happen in your fertility or in your pregnancy, etc. Healthy, stay healthy, maintain a healthy weight, exercise, and you will have better infertility or fertility chances, and you will have better pregnancy outcome.
That makes a lot of sense. And we've talked a bit about how diet and the immune system can impact your ability to carry a pregnancy. But if we take a step back in someone's fertility journey and start with the eggs. So patients hear a lot about the number of eggs.
Everything starts with the egg.
Is there anything that patients can do prior to IVF or concurrent with IVF to improve their egg quality?
Again, an interesting and good question. Many of our colleagues will tell you in response to this question that there's nothing we can do about egg quality. And to a degree, that is a correct answer, but it is a time-dependent answer. Once a woman, let's say, has gone through an IVF cycle and we have retrieved her eggs, there indeed is very, very little we can do, if anything, to affect the quality of her eggs. The question is, can we affect the quality of a woman's eggs while they still are in the ovaries, where they have been from birth on? Those same eggs have been sitting there for all of those years in a very primitive form. In all of that time, can we have an effect on the quality of those eggs? And that is an answer where we only are starting to get the right information, I think. Because, as I already mentioned, women are born with all or almost all of their eggs, and those eggs initially sit in the outer cortex of the ovaries in a very primitive format. And constantly, that is after menarche, constantly some of these eggs are recruited out of this sedentary state in which they are sitting there. And once they are recruited, they are starting a journey within the ovary, geographically a very short journey inside the ovary, but biologically a very long journey, because it can take up to 3, maybe even 4 months, in which this very primitive follicle that was recruited now starts maturing. And in it sits that very immature egg that starts maturing in parallel. And it is really during that journey, which can last, as I said, between 8 weeks or 2 months to 4 months, maybe even sometimes a little longer. It is during that journey that, as we now increasingly understand, the ultimate quality of the egg becomes determined. And the ultimate quality of these eggs obviously has genetic components to it, which were there from the very beginning, but the environment of the ovary during that journey determines most of the ultimate quality of that egg. And the egg is responsible for approximately 95% of the quality of the ultimate embryo. And therefore, you can really say that for all practical purposes, those 8 to, let's say, 16 weeks of what is called follicular genesis, of follicle and egg maturation, that is the critical period where the quality of egg and embryo are determined. And that period is obviously dependent on the environmental influences on the ovary during that time period. And so if you take certain medications during that time period that can affect the ovary, then they may be positive or they be negative. And if we are coming back to nutrition as medicine, I'm sure there is medicine that is better, and there is medicine that is worse, and there's nutrition that is better and that is worse. And we are back to the initial question that you asked me, what diets?
That makes a lot of sense and is really helpful context for women who want to understand more about how they can have some control when they're going through IVF. Now, for patients who might be on their second, third, fourth, and beyond cycle of IVF, we very frequently get asked about what kind of lifestyle changes they can make in order to increase their chances of success in their next cycle. What advice do you have for these patients?
It's another good question, and frankly, a question that we are probably here at the Center for Human Reproduction better qualified to answer than most other IVF clinics, because over 90% of patients who come to us as a last resort clinic have been at 2, 3, 4, 5, sometimes 10 different IVF clinics, and have had many, many IVF cycles even before they come to us. And so this is a question we hear all the time. And the answer to this is unfortunately, again, less specific than I would love to be able to answer it with, because it comes again down to live a healthy life. The healthier you live your life, the easier you make it for us. It then becomes our responsibility, to really figure out why you have had so many failed IVF cycles. And I'm always amazed in many of those patients that they come to us actually without the diagnosis. In other words, they come to us after they have gone through a lot of IVF cycles, often at different clinics. And when I ask them, so what's the diagnosis? Why are you not getting pregnant? No answer. And I always ask them how can you find the right treatment if you don't have a diagnosis? It is like, I mean, who would treat cancer without knowing that you have cancer, right? But yet, in infertility practice, you see this all the time. Lots of IVF cycles, and nobody ever told them what really is the cause or the likely cause for their infertility. So that's really what it's coming down to. What is the cause? And therefore, the question that you asked me and the question that patients ask, doctor, what can I do, is usually quite limited because there's very little they can do. It falls upon us to figure out what's really their problem, or more frequently, what are their problems, because couples frequently have more than one diagnostic problem, and then give them specific treatments for all of these problems at the same time. Because if you just selectively treat one thing, even if you give them the right treatment, it's not going to work if another problem is preventing them from being successful.
Yes, I know for many of our patients, the prevalence of getting a diagnosis of unexplained infertility makes the experience even more frustrating and emotional.
Doesn't
And I,
exist. At the
yeah,
Center for Human Reproduction, the first thing we tell a patient who comes with a diagnosis of unexplained infertility is this diagnosis does not exist, because something remains unexplained depending on how deep you dig. If you just go under the surface, you will have a lot of undiagnosed stuff. If you're willing to dig deeper, you will find out that at the end, there's almost nothing on it. So don't believe a diagnosis of unexplained infertility.
that's helpful insights for people who are looking for answers. And we know that age can play a significant role in fertility treatment. How would the advice that you've given about lifestyle changes and dietary needs change for an IVF patient who's in, say, her 20s or 30s versus one who's in her 40s?
Oh, huge, huge difference. Huge difference. And that is another issue that we are probably more qualified to speak about than any other fertility center in the country, if not in the world. Because when you look at the average at the median age of women who in the US go through IVF cycles, it has been for the last 10 years pretty stable around 36. So roughly half of all patients in the US going through IVF are above 36, and roughly half are under 36. Now, our patients at the Center for Human Reproduction in 2022 had a median age of 43, the following year of 44, and last year in 2024, our median age for the first time hit 45, meaning that over half of our patients starting an IVF cycle during the year 2024 were over 45 years, in comparison to 36 for the average for the country, for roughly 500 IVF clinics. So we have by far the biggest experience with older patients. And that is not by accident. It's now 15 years ago, as a clinic, as a research center, made a conscious decision that the aging ovary should be at the core of all of our activities. Doesn't mean that we are not researching other things, doesn't mean we are not treating other things, but we identified already 15 years ago the aging ovary as the increasingly most important issue in our field of infertility. And that has been, over those 15 years, only strengthened, because it's no secret that our birth rates, like in many other developed countries, are very quickly declining. And when you look at those birth rates in an age-dependent way, you find that all the young women are delaying pregnancy, and that birth in young women are steadily declining. The only age groups where birth rates are increasing are older women. And that is probably reflected in the aging of our patient population that I just described with you. And the reason why we see it, in contrast to most other clinics in the US, because most other clinics in the US, pretty much after age 42 or 43, automatically refer patients into egg donation, meaning they no longer offer them IVF treatments with their own eggs, but push them into using young donor eggs. And in a way, there's a logic behind it, because obviously the eggs of a 25-year-old have a much higher pregnancy chance than the eggs of 43, 44, or even 45-year-old. But as a consequence, all the US clinics together get stuck at age 36, while ours, with us being one of the few clinics that treats routinely much older patients, we are getting more and more of them, and our age, therefore, is increasing. I, therefore, still remember the very early days of IVF when we and other IVF clinics would not accept women above age 38 because we couldn't get them pregnant. But in those days, that didn't prevent us from trying. And so we very quickly learned that we could get women above age 38 pregnant if we changed our protocols a little. And we tried, and we got to the point where suddenly, we got women pregnant till 42 and 43. But then something stopped. And to this day, I do not understand why. Because suddenly the field felt, okay, 42, 43, let's send everybody into egg donation, instead of doing the same thing that we did years earlier and said, hey, we have a problem here. Let's figure out how we can overcome it. And that's where we were 15 years ago when we decided to concentrate on the older ovary. And we, I must say, with a lot of good luck and help from our patients, we have since then learned how to treat older patients much, much better. And most importantly, we have learned that obviously you cannot treat a 45-year-old woman with the same treatments, with the same protocols as a 35 or even a 40-year-old. Everything changes as we get older, not only in fertility, but especially in fertility, because the ovary is the earliest and most radically aging organ in mankind, in humanity. It ages women out of reproductive life by age 45 practically, and by age 46, 7 pretty universal, while we men constantly still produce fresh sperm, not of the same quality, but that's why Charlie Chaplin could still father his youngest daughter at age, 82 or something like that. Okay. Yeah, so aging the aging of the ovary is obviously a huge subject in fertility that, in my opinion, and in our opinion here at the Center for Human Reproduction, unfortunately doesn't get the attention it deserves, because I see it as the biggest problem in infertility.
Yeah, no, it's always so incredible to me to hear about the advances that this field has made, not just in the past decade, the past 30, 40 years, it's even greater. And again, nowadays in New York, you hear about people having children in their 40s almost regularly. So, and I'm sure thanks to many doctors like you who've pushed the limits of what fertility science can accomplish.
Yeah,
and
no question about it. But again, with the caveat that once you get over age 42, 43, while many patients, and I cannot blame them, will not publicly acknowledge it, but if you look at the national IVF statistics that are being published, you will see that there are very few IVF cycles done above age 42, 43 with use of the woman's own eggs. Yeah. Many more are done with donor eggs.
Yeah, and we have many patients come to us and say, oh, well, I saw this celebrity in this magazine, got pregnant at 45. So
yeah. But they obviously don't tell you whether with their own or with donor eggs. That's exactly right. Yeah, and it's a pity, but you have to give them the privacy of being able to choose whether they want to tell or not.
Of course. Um, so I'd love to get your thoughts on when you have patients come into your office for the first time, what's a common misconception they have about fertility treatment or IVF that you wish more patients were aware of?
Yeah, so once again, it is important for everybody who listens to our conversation to understand that our clinic, our center serves a very unique patient population. I'm unaware of a second center that comes even close to it, not only in terms of age, but for example, another statistic that is almost mind-blowing, over half of patients who come to us after they were told that their only chance of having a baby is with donor egg. So I'm therefore speaking from that kind of a standpoint that we are dealing with a very different patient population than most fertility clinics do. And in this patient population, I have to say, at least one of the 2, 3 most important issues that we face is what I already earlier alluded to, which is the ignorance that the patient has at time of presentation, what actually her infertility problem. It's really surprising. It's really surprising. I mean, and very often what I hear is, oh, it's my age. And then I ask, okay, and how old are you? Oh, I'm 41. 41-year-old women get pregnant, at least most of them. Now, obviously, some are not getting pregnant. In some, that may have something to do with the age of 41. But if she has normal 41-year-old ovaries, she should get pregnant. So if it is really her age of 41, it means that her ovaries are not behaving like 41, and that means that she is really in a group of 10% of all women, independent of race, ethnic background, and what they eat or drink, who suffer from what is called premature ovarian aging, which means that their aging process runs a little bit ahead of everybody else. Then you have a diagnosis. And once you have that diagnosis, then I can tell you, okay, if you have a diagnosis of premature ovarian aging, I bet you once we test your androgen levels, which nobody is testing, we will find that your androgen hormones are low. Those are the male hormones. And ovaries need good androgens in order to make good eggs. And many of those women, all they need is to raise their androgen levels once they have the diagnosis. And many of them, not many, at least some of them will get spontaneously pregnant while maybe even waiting to get into an IVF cycle. So it all starts with knowing why they are in an infertility clinic. And I'm always amazed how long many of these women are in infertility treatments, often in many places, without ever knowing why they are there. Okay, so that is clearly the first issue that always kind of tickles us into writing papers and arguing against this practice. A second issue that we are also struggling with very, very frequently, I mentioned it already briefly, is the misunderstanding, even by many of our very competent colleagues, about the importance of the immune system in normal fertility. There are some excellent fertility centers, fertility clinics, where patients will hear, oh, immunology doesn't matter, okay? And they hear it till today. And that is, again, in our opinion at least, a very, very big mistake, because without a proper functioning immune system, no woman will get pregnant. And if the importance of the immune system is not understood, if they do get pregnant, they will have miscarriage. So that is probably the second biggest issue that we face in our patient population. And the third biggest issue is probably the fact that the infertility field, unfortunately, has undergone what I have called in some of my writing industrialization, meaning, when I, as a first generation IVF doctor, started in my first IVF clinic in Chicago in those days, 95% of IVF clinics that got started in those days were run by physicians, were owned by physicians. Some were owned by hospitals, but most were owned by physicians or small physician groups. And they had a very strong incentive to have good results because it wasn't covered by insurance or very little covered by insurance, and therefore patients had to pay out of pocket. And therefore, they cared what the results were. And they, to say it bluntly, they went to the clinics that had better results. The picture today is very different. Today, only a minority, and a very quickly dwindling minority of IVF clinics is still owned by physicians. Most are not even owned by hospitals or universities. Most are now owned, or many, almost half, over half of all IVF cycles in the US are already performed in clinics which are owned by outside financial interests, so Wall Street, equity, private equity. And that creates a completely different environment. And that creates a marketing environment. It creates a revenue-driven environment. It obviously creates a profit-driven environment. I'm not trying to say that doctor-owned clinics don't want to make a living and don't want to have a profit, but the intensity of that process is quite different, as I'm sure everybody will understand. And as a consequence, the importance of success in choosing your clinic has disappeared, or at least to a large degree disappeared. And what much of the public really does not understand is that clinical pregnancies and live birth rates in IVF constantly have improved since the early days. But by 2010, they reached a plateau. And after 2010, they started actually declining. And the chance of a woman using her own eggs to get pregnant and have a live birth in a fresh IVF cycle is significantly lower than it was in 2010. Yet at the same time, that IVF cycle is dramatically more expensive than it was in 2010. Nobody's talking about it. We have been publishing it, and we are trying to be outspoken about it. But that is obviously a circumstance that deserves attention, and more importantly, that deserves explanation. And again, we published some papers on this subject, and we have come to the conclusion that much of that decline is the consequence of what some of our British colleagues have given the term add-ons to IVF, which are kind of alleged improvements in IVF, but which, if you look deeper, one by one, not only do not improve IVF outcomes, but actually, at least in certain subpopulations of IVF patients, reduce pregnancy and live birth. So in that sense, I think our IVF practice has not changed to the better, very much to the contrary.
Well, I've learned a lot of new things from this conversation. So much about how the immune system impacts women's ability to conceive, about androgen levels and how they impact fertility. and then just the overall history of the IVF field. This has been so valuable for me to learn more, and I'm sure so helpful for our many patients who have a lot of questions and are looking for trustworthy answers. So thank you so much for the time. I know your schedule is very packed meeting with patients, so I know our thousands of patients are going to be really excited to have access to your expertise. So thank you.
My pleasure. Thanks for having me. Bye-bye.